Good evening. My name is Professor Leanne Young. I teach the newborn maternal and fetal medicine class for Fortis College. This week we're covering week 8 content. So we're going to be talking about the newborn nutrition and high-risk newborn care. We'll start here by talking about newborn nutrition and feeding. So first, whenever we're discussing nutrition and feeding, we need to discuss what is the nutritional needs of the infant. So here I have them all listed for you. So for fluids, we'll start there. Fluids. During the first 2 days of life, they need at least 80 milliliters per kilogram per day. Days 3 to 7, it increases to 100 to 150 milliliters per kilograms per day. Fluid is lost typically through urination or respiration, and we have to monitor the baby closely for intake and output, right? So we need to make sure mom and dad understand how many wet and dirty diapers a newborn should have within the first couple weeks of life, okay? To make sure that their nutritional needs are being met. For their energy source, this varies per age, weight, maturity level, thermal environment, and growth rate, okay? So the fat portion of human milk provides the greatest source of energy for our babies. Moving on, we'll talk about carbohydrates. Lactulose is the primary carb found in human breast milk. This is the most abundant carb found in newborn diet up until 6 months of age. Lactose provides calories in an easily identifiable and available form. Its slow breakdown and absorption also increase calcium absorption. Um, let's see here. Let's move on to our fats. The human milk is comprised of lipids, triglycerides, and cholesterol. Cholesterol is essential for brain growth and development. And if not feeding breast milk, then we need to ensure that there is fat in the formula or an alternative feeding method is being used. Breast milk contains casein and whey, okay, as this is underneath our protein section. So human milk contains two proteins, casein and whey. The primary whey protein in human milk is A-lactalbumin, which is high in the essential amino acids needed for growth. This also has iron binding capabilities and bacteriostatic properties. The casein in human milk enhances the absorption of iron, which prevents iron-dependent bacteria from infiltrating in the GI tract. Okay, so our vitamins. Human milk contains all except vitamin D. This is important to know whenever we're talking to our patients and our parents about supplements, what babies should or should not be getting. Okay, we need to have mom increase her vitamin D intake while she is breastfeeding, or supplement the baby with vitamin D drops or whatever the newborn provider is going to suggest. Vitamin K, we're going to talk about this a lot. We talked about it a little bit when we talked about bilirubin synthesization. Vitamin K is required for blood coagulation. It's produced by intestinal bacteria. And then we know that newborns do not produce this for a few days. Vitamin K is one of those vitamins that newborns cannot make immediately. It takes about 2 weeks for the newborn to be able to fully develop and synthesize their own vitamin K. So that is why it's important that we give them that medication immediately after birth, because it helps with their coagulation and their clotting. From a mineral standpoint, iron levels are low in all forms of milk. Breast milk is better than formula or cow's milk in iron content. So iron levels are low in all forms of milk. Breast milk is better than formula or cow's milk in iron content. Infant stores of iron are going to deplete at 4 months, so they're at risk for iron deficiency. So this is something that we need to keep track of and tell our patients about. A good indicator if the baby is getting the proper nutrition and meeting their nutritional requirements is by how much weight they're gaining. If they're meeting their checkpoints at each visit and they're gaining appropriate weight, then we know that their nutritional needs are being met, okay? If they are having correct amounts of intake and output, then we know their nutritional needs are going to be met. First, we're going to talk about breastfeeding, okay? So, in general, more patients are choosing to breastfeed their babies. It's risen steadily over the past decade. CDC reports about 84.1% of moms in 2017 are going to be breastfeeding their baby. Lower rates are in Hispanic or in Black Black populations, excuse me, according to the study. There are a lot of benefits for both mom and baby whenever it comes to breastfeeding. Okay, you'll hear the term breast is best. We as nurses are not going to be pushing breastfeeding on anybody. We're not going to be telling a mom that she's a bad mom because she didn't breastfeed her baby, because that is just false. But we do want to tell them about the nutritional benefits and other benefits that are associated with breastfeeding. That way they are aware whenever they're making an informed decision. Okay. So in your textbook, page 583 has a table that goes through all of the benefits for mom and baby. There are so many. I can't go through them all with you. But there, take a peek at that. It's really awesome. One of the biggest ones is that it reduces infant mortality rates. Okay, breastfeeding the baby is going to reduce infant mortality. It also reduces the risk for GI infections, Crohn's disease, ulcerative colitis, obesity in childhood, and type 2 diabetes. Breastfeeding is unique. It's the gold standard for an infant nutrition. Composition will change to fit the growing needs of the infant. What does that mean? Mom's breast milk and mom's body are going to change the content and the makeup of the breast milk in order to get the baby what the baby needs, which is pretty amazing. Okay. It's easily digested by the newborn, and it's important in regulating inflammatory response. There are a lot of reasons why moms may or may not choose to breastfeed, okay? This could be because of cost, because, excuse me, because of cost, because of accessibility. If moms have to go back to work 4 weeks after having their baby, there's a very good chance that they're going to be formula feeding, because pumping, going back to work that soon, and also making sure baby is well fed it's a lot of pressure on a mom. So some environmental factors that are listed here would be like demographics, cultural beliefs. Some cultures may or may not think breastfeeding is um, important and what they want to do. Um, some people just are not educated on the awareness of or aware of the benefits of breastfeeding. They may not have the support. It also depends on how many kids they have. A mom who has 6 other kids running around that she has to feed and take care of is going to be less inclined to breastfeed, because it does take some more time and it is a little bit more involved. Education and employment are big ones too. If a mom's in school, like if she's in nursing school and she just had her baby, breastfeeding is going to be very difficult because it is so time consuming. Some contraindications do exist for breastfeeding. So, any underlying maternal or fetal medical condition. So, if a baby is in respiratory distress, we're obviously not going to try to latch that baby and breastfeed that infant right then and there. Okay. Um, Moms that have a positive HIV or have an active HIV infection are not able to breastfeed because it can transmit to the baby. So they may need to supplement if infant is not gaining appropriate weight. So if a mom is trying to breastfeed exclusively and her baby is not hitting all the milestones, we need to educate that mom that you can continue to try until we get to the point where we need to supplement this baby for the baby's health and safety. And then we need to have the discussion with her about her options, formula, donor breast milk, whatever it may be, to supplement that kiddo to get them to the appropriate weight. Breastfeeding with the LGBTQ plus families. This is something that we as nurses can still help them accomplish by breast milk. If the family has decided to use a surrogate, whatever the arrangement is, the surrogate may provide breast milk if they are willing to, and that's part of their contract that they sign prior to the delivery of the infant. Okay. Some other things I wanted to mention to you guys before we go to the next slide. As far as benefits for mom with breastfeeding, this is known to reduce risk for ovarian cancer, type 2 diabetes, hypertension, myocardial infarction, and it enhances bonding for both mom and baby, obviously. So here I have listed breastfeeding benefits for baby and breastfeeding benefits for mom. You can take a peek at that. This chart here shows another good examples of why breastfeeding is best and associated with the benefits for both mom and the baby. Okay, let's talk about our anatomy and physiology of lactation. So the breast, as we know, is made up of 15 to 20 lobes. Within each lobe is tissue consisting of what we call alveoli. You guys have heard this term in the lungs. This is the same kind of terminology, but it's used now to describe the breast tissue. Each nipple has multiple pores that are going to transfer milk to the suckling infant. Milk ducts transport milk from alveoli to nipple. The size and shape does not impact the ability to produce milk. So a woman that has larger breasts does not necessarily mean that she's going to produce more milk than a woman with smaller breasts. It really has no effect on the breast milk production at all. Breast size is going to increase, the veins become more prominent, nipples will become more erect, the areola is going to darken and enlarge. Okay, 16 weeks, the alveoli begin producing prepartum milk, so they begin producing that colostrum. So sometimes moms can hand express or will start leaking earlier in their pregnancy. They may start already producing milk. Okay, when we talk about the physiology of breast milk and breastfeeding, we need to talk about what's called lactogenesis. So, this is the entire process of how milk is being produced, and you guys are going to want to know this, specifically the hormones that are participating in the production of milk. So, after delivery, we have a huge fall in progesterone, which triggers the release of prolactin from anterior pituitary gland. What does our prolactin do? Okay. During pregnancy, prolactin prepares the breast to secrete milk and and start lactation to synthesize and secrete milk. Okay, so during lactation to synthesize and secrete milk. So pregnancy, prolactin is going to prepare the breast to secrete milk, and during lactation, it's going to synthesize and secrete milk. They are highest during the first 10 days after birth, and they gradually decline over time, but remaining above baseline levels for the duration of lactation. Prolactin produces in response to infant suckling and emptying of the breast. So that baby suckling on mom's breast tissue is ultimately going to stimulate the release of prolactin, which is going to stimulate milk secretion. Okay, it's a supply meets demand system. So the more that baby is suckling on the breast, typically the more milk that mom is going to be producing. If milk is not fully emptied, so if that baby hasn't sucked for long enough, or we don't have long enough bouts of of baby to breast, or mom isn't pumping to make sure that she's fully emptied, this can actually contribute to a decline in her milk production. So for those moms who um, say that they are just not producing milk very well, we need to educate them on all of these points so that they know that to make sure that they are doing the things they need to do to increase their milk supply. Oxytocin is the other one that is essential in lactogenesis. So we have prolactin and we have oxytocin. These two are very important in lactogenesis, and you guys will need to understand them. So milk ejection, oxytocin is the milk ejection reflex, or we call it the letdown reflex. So as the nipple is stimulated by the suckling infant, the posterior pituitary gland is prompted by the hypothalamus to produce oxytocin. This hormone is responsible for the milk ejection reflex. The myoepithelial cells surrounding the alveoli respond to oxytocin by contracting and sending the milk forward through the ducts to the nipple, and the milk ejection reflex is triggered multiple times during feeding session. Thoughts, sounds, and odors that mom associates with her baby can trigger oxytocin and can trigger a letdown or her milk to be released. Sex can trigger this as well because oxytocin is released with an orgasm. So sometimes moms will have leaking with sex. Reflex is inhibited by fear, stress, and alcohol consumption. So patients who have a high stress level, especially in the immediate postpartum period, are actually going to decrease their milk supply because stress is going to inhibit that oxytocin release. Oxytocin is also going to stimulate uterine contractions, as we know, right? So that means that moms are going to be crampy with breastfeeding sometimes. So sometimes we need to educate them about taking medication before to help prevent discomfort. The nipple erection reflex. So this is whenever an infant cries, suckles, or rubs against breasts, the nipple becomes erect, which assists in the ejection of milk. Inverted nipples that do not become erect will need help latching the infant. So we always need to help our patients latch their babies but especially with an inverted nipple, we may need to help a little bit more. Okay, this I have a little chart here about your prolactin and your oxytocin. We have here the 10 steps of successful breastfeeding. That's important from each hospital. Usually each hospital has this posted somewhere. And you guys can review that on your own time. Okay, so whenever we're helping a mom initiate breastfeeding, we need to first observe for feeding and readiness cues from the baby. Okay, so if baby is doing suckling or mouth motions, hand to mouth movements, the rooting reflex, we need to ideally try to latch the baby within the first hour, but we need to look for all of these things because that is going to indicate to us that this infant is ready to latch. With positioning for breastfeeding, mom is going to dictate this. There are four traditional positions. They are the football, cross cradle, cradle, and side lying positions, which I have a couple pictures in the next couple slides. We need to prioritize making mom as comfortable as possible. When we talk about the actual latch, we need to place the infant's mouth over the nipple, areola, and breast. All of that needs to fit in the baby's mouth. Not all of the breast tissue, but the nipple, areola, and the outlying part of the breast. Um, Making a seal, making sure that mouth is sealed all the way around, that there's no like gaps, that we're not hearing any noises because that can indicate that we don't have a proper seal. We have mom express colostrum to her nipple to stimulate that baby to suck. This helps baby open their mouth wide, and then we need to look for an appropriate latch. So, what is an appropriate latch? We ensure that there's a full seal, no noise is heard, mom reports a tugging sensation rather than a pinching sensation. Um, and then that mom is not severely sore following feeds, no redness or raised areas on the breast tissue. So you guys may have heard about the letdown. Letdown is whenever more of mom's milk is being produced, not just colostrum. It's when her milk comes in. Signs that's occurred, mom might feel a tingling sensation, baby sucking pattern changes to slower, more drawing sucking pattern, and then you might hear some audible swallowing. The frequency of feeds. How often do we need to feed our baby? 8 to 12 times in a 24-hour period. Babies are not going to wake up on their own to feed, so parents need to keep track of feeds. They need to set an alarm. They need to wake the baby up in the middle of the night. It's not the most fun thing, but they have to do this in order to make sure baby's getting the appropriate amount of intake. Once the infant is older, demand feeding is appropriate. Feeding the infant whenever feeding cues are on display. So if a baby is making those rooting motions, we need to latch that infant. A mom should be feeding about 15 to 20 minutes per each side. Length is going to decrease as the infant gets older because the baby is drawing out more milk and mom is producing more milk in a shorter period of time. How do we know that breastfeeding is effective? There's a box on page 592 that goes through that for you. Um, but we monitor their intake and output. We monitor their weight at office visits. We also need to encourage a feed diary or a log that mom and dad will keep to make sure that baby is getting the appropriate amount of feeds. Assessment. We should observe at least one feed in a 12-hour period during your shift on the floor. If you were working as an L&D nurse on the floor, you would need to observe and put in a latch score on your patient at least once. And then your latch score and assessment are going to be per your hospital policy. So, how do we know baby is feeding effectively? How do we know breastfeeding is effective? For the mom, she's going to have onset of copious milk production by day 3 or 4. There's going to be a firm tugging sensation on the nipple with no pain. Uterine contractions are going to occur while feeding. She feels relaxed. She has increased thirst. Breast will soften. She may feel the letdown. For baby, latches without difficulty, has bursts of 15 to 20 sucks or swallows at a time. We can hear baby swallowing. We can they easily release his breast at the end of feeding. They appear content and relaxed after feeds, and they have at least 3 substantial bowel movements a day after day 4, and then usually about 6 to 8 wet diapers per day after day 4. Here I have a latch score assessment example for you, as well as an example of the different breastfeeding positions that are very common that we help patients latch their babies in for you guys to review. If a patient is having difficulty feeding, we need to talk to them about supplements, bottles, pacifiers. We should not supplement unless a mom desires or there's a medical indication. Why would we supplement? For babies, if they are not having good blood sugar control, if they have hypoglycemia, if they're dehydrated, if they are losing weight, if they are not having bowel movements or having appropriate amounts of urine output. For mom, if she has delayed lactogenesis, if she has intolerable pain with feeds, or if mom is on specific medications that are prohibiting her from nursing. So, how do we supplement a baby? Formula, donor milk, or expressed colostrum and breast milk from mom. So, like if mom pumps. So, we could have mom pump and feed the baby whatever mom pumps out. Okay. Um, we can use a syringe, a cup, a spoon, a shield, or a dropper to supplement our babies. We need to educate patients to delay pacifier use until a proper latch is obtained because that can cause nipple confusion. Okay. Some things that may impact feeds in a negative way is if your baby is sleepy, if we have a fussy baby, if they're not gaining weight easily, if they're jaundiced, and then obviously preterm infants or multiple infants are going to pose their own challenge. Here in this top left picture, I have what's called a nipple shield that helps with breastfeeding. I thought this picture of the pacifier was really funny. That baby looks like he has a mustache. And then here, this is a cup feeding baby when we supplement with a cup. Expressing and storing breast milk. So hand expression can be more effective than a mechanical pump. This is going to be instructed for a patient by a nurse on the floor. Hand expressing is just taking your hand like in the shape of a C, placing it around the base of the breast and pulling forward, massaging forward that milk, okay, the colostrum or the milk, typically onto a spoon, which then can be spoon fed to our baby for supplementation. Pumping. This should begin once milk comes in, or if there is a delay in latching the infant. So if the baby has to go to the NICU, or if mom and baby are separated for whatever reason, then we should start pumping with mom immediately. Double pumping saves time and produces milk better, so mom pumping each side at the same time. The flange of the pump should be measured to appropriately fit mother's breast. Usually it comes with a kit that has a little like measuring tool in it to help moms decide which flange will fit them best. Moms should be educated on their pump prior to discharge by a lactation consultant or nurses. Here I have a picture of the breast milk storage guidelines and what we're specifically looking for. Um, how long milk can last in the freezer, the fridge, or at room temperature. Other considerations with breastfeeding. Whenever a patient is returning to work, this often leads to a decrease in breastfeeding. We have to help the patient set goals, give them education on pumping and storage, and then also educate them on portable pumps. If they are weaning off of being breastfed, for exclusively breastfed babies, this is done when the infant is introduced to other foods, not feeds. It should be gradual over months. If they do it abruptly, it can be more disruptive to the baby. Another thing we can do is milk banking. So this is pasteurized donor milk. What we're talking about donor milk. It's a great option for moms who cannot breastfeed or infants who need supplementation. It's just breast milk that's donated that typically insurance will cover if there's a medical indication for using it. Milk sharing. The infant is nursed by a woman other than the mom, or purchasing breast milk from a friend or external source. So there's other things that we can do if mom cannot breastfeed herself. Care of the breastfeeding mom. We need to take care of mom. She's taking care of that baby. She's putting in a lot of energy and time into nursing this newborn. So, with nutrition, they should add about 400 to 500 calories a day. Breastfeeding makes you hungry and thirsty. Dramatic weight loss is not required. So, like, patients should not lose like drastic amounts of weight postpartum because that can decrease milk supply. They need to rest a lot. Fatigue, stress, or worry can reduce milk production. With breast care, we tell them not to put soap directly on the nipples because that can have a drying effect. Use breast cream, use nipple creams, use lanolin, wear supportive bras. Um, Breastfeeding is not an effective contraceptive method. We have to tell moms that they still need to plan on using birth control in order to prevent a pregnancy. Okay. Um, Breastfeeding during pregnancy. So if mom were to become pregnant again, it's okay if there's no medical contraindications. So for example, if mom is pregnant and she had a history of a preterm baby, we would not want her to be breastfeeding because that can increase her likelihood of having uterine contractions. Breastfeeding after like a breast surgery, a breast reduction or enhancement, this can affect the ability for moms to produce milk. Mom can still attempt and we can still help her, but it may not go as well as she wants it to. If a mom has nipple piercings or tattoos on her breasts, it's safe for them to breastfeed the baby, but she should wait to get a new tattoo until the infant is weaned. So moms shouldn't be getting tattoos whenever they're breastfeeding. Obesity, patients who are obese have less success with breastfeeding overall. Medications, herbs, and substance use. We need to ask the doctors about any meds and herbal remedies. And then substance use must be avoided during breastfeeding. So, common concerns of the breastfeeding mom, you guys are going to want to know about engorgement and mastitis for sure. So, engorgement is a common response of the breast to sudden change in hormones and onset of larger amount of milk production. It typically occurs with letdown. It's what happens when your breasts become firm, tender, and hot to the touch. They're a little bit painful. In order to treat, we hand express milk from the breasts. We feed more frequently. We use ice packs and anti-inflammatory medications. For nipple discomfort, we're going to tell mom to use nipple cream and then observe the baby's latch and make sure that the latch is correct. For clogged milk ducts, this is a result of inadequate removal of milk from breasts. So, for treatment, we need to apply a worm compress to the area and continue to nurse the baby and wear supportive bras. This increases the likelihood of developing other milk duct related infections. So, we need to educate our patients about that to be aware and watch for any signs and symptoms of a mastitis or something else that's developing. Insufficient milk supply is a common reason why women will stop feeding. The treatment would be to increase skin to skin time, encourage more frequent feeds with pumping by either hand expression or mechanical, and then check that meds are not interfering. So, some medications like SSRIs are going to dry out mom's breast tissue and dry out her breasts. Mastitis is that infection of the breast. Signs and symptoms would be like flu-like symptoms, high fever, chills, malaise, body aches, headache, nausea, and vomiting. Some risk factors would be not emptying the breast all the way, stress, fatigue, maternal illness. Treatment would be to continue to nurse on the affected side, give mom antibiotics, bed rest, and anti-inflammatory meds. If mom is sick, she should still be breastfeeding her baby. Okay, that's not an indication for to stop. So here I have a couple pictures of an engorged breast, and then I also have one here about mastitis, which this one on the right is really, really bad. Okay, when we talk about formula feeding, if not breastfed, the infant should receive commercial iron fortified formula. The formula preparation and feeding guidelines are on page 630 of your textbook. Feeding patterns for formula fed baby 15 to 30 mLs per feed in the first 24 to 48 hours because that baby's stomach is really little, so we're not going to be like overwhelming them with like a large amount of formula. 90 to 150 mLs of feed by the end of the second week of life because then the stomach is the size of a large egg and they can tolerate more intake. We want to feed every 3 to 4 hours. No rigid feeding schedule, 6 to 8 feedings typically in the first 24. Infant should be held for the feedings. The bottle should be angled up to make sure they're not getting and sucking in a bunch of air from the bottle. And we need to burp the infant several times to decrease spitting up. So here are your formula feeding guidelines, how to prepare and store powdered infant formula. Okay, I'm going to pause this recording. This recording will be in two parts. So in Canvas, you will have the option to listen to the Chapter 25 High Risk Newborn lecture. But this one we just covered was over newborn nutrition and feeds. Thank you.